Everyone, happy Thursday. Welcome to Virtual Morning Report. It's yet another edition of um, our CP Solvers team members jumping in and co-facilitating today. And I'm thrilled that Marcella is going to be joining us and co-facilitating, which is really, really exciting. And I'll pass the mic to her to say a quick hello.
Hi everyone, welcome. Really happy to be here. Really excited for the case. I hope someone has a case for us. My name is Marcela. I'm a doctor from Brazil. I graduated last year, and yeah, that's it. Let's go.
Woohoo! I love it. You're like introducing yourself in 30-minute VMR style. Very brief, very quick. Marcella has a big step 2 coming up and is kind enough to take the time to do this in the middle of that, which is awesome. Yeah, so if any of you have a case, please let us know. We would love to hear it. I'll let folks in from the waiting room. Also, thank you to everyone who turned their video on. Hi, Ariel. It's nice to see you again. Hello. Hans, you're at work, huh? Hello. Keep working hard, my friend. I also see Yasmin.
No, this morning hardly working. It's a quiet clinic.
It's a quiet day? Good. I'm so glad to hear that. I'm so glad to hear that. I also see Ines is here. Am I pronouncing your name correctly? Yes. Oh, that means I didn't.
Yeah. No, it's Ines.
Ines, wonderful. Ines, where are you calling from?
So currently I'm studying in Bulgaria, but I'm French.
Yes. Oh, that's right. That's right. No, I think we met a little while ago. It's so good to see you again.
Thank you.
Maria, what's up? Nilayan is here too. Syed is here. Oh my God, it's a VMR party. Subangi is here. Oh my God, I don't know what to do anymore. So many people turned their video on. Thank you. Y'all, it's Marcella's first time facilitating. So please let us know if you have a case in the chat. We would be very grateful to nerd out with Marcella. Marcella, you're getting record crowds here.
Yeah, I'm really happy to see that.
All right, it's really cool.
Yeah, that's amazing.
Oh my gosh, Ines, you're way too kind. Yes, please. We'd love you to present. So now that you're doing that, do you want to tell us a little bit more about yourself before we jump in?
Yeah, absolutely. So hello, I'm really happy to be with you guys. I love this space and I've been following, for quite some time. It's really hard to join sometimes, but anyways. So my name is Ines and I'm a 6th-year medical student. So I'm currently studying in Bulgaria. And I think that's it about me.
Oh gosh, no, we're not going to let you off the hook. What do you enjoy most outside medicine?
Okay, so I do a lot of massage, Swedish massage.
Wow,
yes,
that's awesome.
And I really like it.
Yeah. And where do you see yourself after medical school? Are you going to stay in Bulgaria, or do you see yourself going elsewhere? What do you think? Where do you think you'll be calling from a year or two from now?
That's the big question. Yeah. Everyone asks me that. I don't think I will go back to France. Yeah. I mean, yeah, but probably Sweden.
Awesome. Well, we can't wait to see your journey grow. And thank you again for teaching us with your case today. I will hand you the mic, and I'm excited to nerd out with all of you and Marcella.
Thank you. Okay. So I'll just give you the presenting complaint. Okay. So give me just 1 second. Just take the case.
Take your time, please. There's no rush.
So we have a patient. So it's a 66 years old farmer that presented in our emergency department for aggravation of dyspnea, persistent chest pain, and fever for the last 3 days. So I will stop here maybe.
I'm so happy, Marcella, future ID doctor, that you're getting fever, shortness of breath, and chest pain. What are your thoughts?
Yeah, I'm really happy when I heard fever. But so let's go. I see we have a case of a male, and he's a farmer. When I heard farmer, I already thought about exposure, especially now that we have fever. So it's something to consider. And when I heard chest pain, of course, first I thought about emergency cases. So the 422, the 4 heart, 2 lung, and 2 esophageal causes. But then we have fever, and when we have fever, we think about inflammation. So inflammation, we actually think about infection and malignancy or autoimmune. Since he's older and he also has dyspnea and chest pain, I'm quite more worried about infection and maybe a malignancy. But since it's 3 days, it's more acute. It makes me think more about infection. Yeah, that's it. And also, since he has dyspnea, and he's in the ER department, I am really worried about the oxygen, the saturation. So first I would check if he has something that I need to act now. So check if he has low oxygen, if I need to be worried with an intubation or something like that now. And what do you think, Rabbi? I don't know if maybe you can help me to choose like the center of gravity here. So yeah.
Yo, do you think she needs any help? Anybody think she needs any help? I should just stay muted the whole time. That was superb. I think what you're doing, what you're teaching us is how you were using the time course as a filter for fever, and also reminding us that in patients with morbid complaints like chest pain and shortness of breath, sometimes you have to act before you know what's going on. I think that's very wise. I'll only comment on your question because I think that's a very wise one. And here's the tension. Chest pain usually prioritizes a cardiovascular cause over a pulmonary cause, but fever prioritizes a pulmonary cause over a cardiac cause. Why? Fever usually means infection, and infections tend to occur in places that have direct access to the outside world. With lungs being open to the world are much more likely to have an infection than the heart. That doesn't mean the heart can't get infected. Endocarditis, especially in a farmer, myocarditis and pericarditis are very, very important things to consider. But I think the center of gravity of the disease here is a tension between the heart, chest pain, and the lungs, fever. And in all comers, I think the lungs win. So here, I think we're probably dealing with a pulmonary disease process, but we should not assume that. And we should also actually be open to the small possibility that there is a systemic disease manifesting in the chest through metabolic acidosis, so abdominal process and dyspnea, or anemia. So it may not even be in the chest at all, but it's probably in the lung. All right, Ines, back to you.
Okay, so I'll jump on the past medical history. So he has obstructive sleep apnea. He's on CPAP since 2017, so treated, there's no problem. He also has hypertension, which is also treated since 2016. So I'll give the medication after. And he has obesity, so with the BMI of 33. For the medication, so he has Taor, Loxane, Coaprovel, and spironolactone. So those are mainly for the heart. Yeah, this is French name, so I'll give it to you after. And then for the family history, there was nothing very significant. Social history, no history of smoking, pets, or recent travel. In terms of health-related behavior, he doesn't drink alcohol, doesn't smoke, so there was really nothing, and no allergies. So do you want me to continue? Or yeah. So his vitals, heart rate was 64 beats per minute. The blood pressure was 112/68. Temperature was 39 on admission, but then it resolved. So he came with fever, but like a short while after, it was fine. And saturation is 91% on room air. For the physical exam, so general, he appeared as an obese man, alert and dyspneic while at rest. Cardiovascular examination, there was nothing particular. In terms of pulmonary examination, he had dyspnea at rest. On inspection and palpation, it was asymmetric expansion and reduced tactile firmitus. On auscultation, absent breath sound on the left side. And on percussion, dullness over the area of effusion, so on the left side. The abdomen was soft, non-tender, non-distended, no organomegaly. Neurologic exam, no sensory motor deficit, so everything was fine. No edema, no lymphadenopathy, and I will stop here.
Enlighten us, please, Marcella. Ines, I just want to say this is such an incredible presentation. You're also presenting at a pace that allows us to really do this in 30 minutes. So thank you very, very much. All right, Marcella.
So thinking about the past medical history, I think like the sleep apnea and hypertension, I am keeping that in the background, maybe a risk factor, but I don't think will play much here. Maybe more like he's a farmer would be more like a risk factor to consider. I see that he's having a fever and a low heart rate, and I don't think he's using a beta block. So I'm considering maybe a Faggot sign. And since he's like a farmer, it could be like Q fever, brucellosis, or some infection, Legionella, something like that. And especially because I see he has an asymmetric auscultation in the lung. So once again, we have our center of gravity in the lung, especially with the low saturation. And yeah, I think that's my first thoughts. And also maybe trying to go back to the history and check if he has any other localizing sign, if he had, for example, diarrhea or something like that that he didn't mention. Try to characterize the chest pain, if maybe that helps. And the fever, if it has a different pattern or something like that. What do you think, Habi?
Marcella, that's amazing. And yes, I think you're making her day by letting her talk so much about ID, teaching us about Faggot sign, infections associated with farming, and using the word center of gravity. It's amazing. Also wanted to thank Nikita, Robert, and I see Amar is also joining. Thank you all for turning your videos on. It really makes my day. Thank you. You know, I think the rest, just to comment on the rest of the data, I have nothing to add to your analysis, is what does the lung exam mean? And if you analyze the lung exam strictly, you're saying that there is asymmetric auscultation. So there's something on the left side. And the question is, what is it and where is it? So the question is, what is it and where is it? What is really, is there air in the way or is there fluid in the way? And when you see dullness, you don't know, dullness to, when you see distant breath sounds or reduced breath sounds, you don't know if there's air between your stethoscope and the lungs or there's fluid. But then the dullness to percussion tells you that it's probably fluid, in contrast to resonance to percussion, which would be air. So what is it? Is fluid. Where is it? The fact that there is reduced breath sounds and not crackles tells you that you're probably dealing with stuff in the pleura. So this exam is very characteristic of a pleural effusion. Now, I'm going to ask the chat just to involve you all, just to focus on one question for me, if you don't mind. Why would somebody with a pleural effusion have a SAT of 91%? What is the mechanism of hypoxemia in a pleural effusion? I'll give you all 30 seconds. All right, superb answers, my friends. Folks are saying, to summarize, atelectasis or VQ mismatch. That's correct. So pleural effusion shouldn't do anything to the lungs unless it compresses the lungs. So most people with pleural effusions don't have hypoxemia from pleural effusions, especially if they're unilateral. Why? The other side can compensate. So here, either this is a large pleural effusion, extremely large, or more likely, there is hidden disease behind that pleural effusion. The localization of a pleural disease process camouflages, hides the ability for you to detect lung pathology because that fluid is in the way, right? So you can't hear those crackles even if they were there. So for me, I always step back and say, when there's hypoxemia and a pleural effusion, it's a diagnosis of exclusion to assume that the pleural effusion is causing the hypoxemia. And you have to be open to the possibility of lung disease that is hidden as a result of the pleural effusion. That's an especially prominent hypothesis given the fever, which tells us that this is probably an empyema, and most empyemas come as a result of a parapneumonia or pneumonic empyema. So Marcella, I think your hunt for an infection has gotten even more credence. The pleural space is almost certainly involved, but we have to remain open to the possibility of what else is involved. And given the hypoxemia, I would want to make sure there isn't lung involvement as well. All right, Ines, back to you.
Thank you. That was really interesting. So on the blood test result, so we had white cell, 94% neutrophil. Okay, I don't have like exactly all the chemistry and others, but it was quite normal except the CRP, which was 192 milligram per liter. And yeah, the rest was normal. I can show you a chest X-ray. What happened is that we drained the patient once. And this is what happened 2 days after. So let me share. Can you see it? Oh, wait, let me put it. No. Yeah, I don't know how to. Oh, here.
Yeah, perfect.
So this is, we drain him. And this is still 2 days after.
Wow.
Yeah. So I'm not going to tell you the Torres synthesis result because it's going to give you the answer. I'll wait for what you have to say.
All right, Marcella, mic to you, my friend. Ines is making this a real teaser.
Yeah, I would love the results. So I can see in the X-ray that we confirmed our hypothesis for the pleural effusion. And it's quite big, which impresses me because, like Rabbi was saying, that's exactly like the cause of the low oxygen saturation. And I am wondering, like in my mind, why this pleural effusion is so big? What happened there that made it so big in 3 days? And yeah, that's my thoughts, because like she said, the other exams, they were normal, and it makes me think about something that is making the lungs recollect the liquid there, because she said they drain it and then it's back there. So yeah, my thoughts are, and I don't know.
Yeah, I love that. I think you're teaching us when the pleural fluid accumulates, it's probably because of an uncontrolled process. And I think this is the time where none of us know, and we need the thoracentesis results to tell us what the answer is. And then this is the value of VMR, is you get to practice your knowledge. So Marcella, I know you love infectious disease. What can you teach us about a farmer who gets a lung infection, pleural infections? What diagnoses? You mentioned some of them earlier, but just to take a minute or two to talk about what your short list would be of a pneumonia or a pleural effusion in a farmer.
Yeah, so I was thinking that, I know, like, for example, I was thinking Legionella, brucellosis, or fever, because I know they can affect the lung, also the Faggot sign, but usually they don't present, it's not so common to present like this. a localizing disease, and it's usually diffuse. So usually when we have a pleural effusion like that, it would be a more aggressive pathogen, especially in 3 days. So usually staph aureus, something like that, to cause like a really an VMR or something like that.
Oh, so good. I completely agree with you. You're reminding us of the importance of staying humble. This is not just a farmer. This is a human being who is also a farmer. So staph aureus, gram-negative rods are very important to think about. Now, there was one final clue on that image, which it's hard to appreciate it, but they described a cystic lesion. So does that do anything for you? What do you think about the cystic lesion in a farmer?
Cystic lesion, yeah, if it was in usually like a parasite forming a cyst, but it could be like a cavity. So it could be fungi like histoplasmosis, or tuberculosis also can cause like this cavity, a cyst, or a parasite like echinococcus can cause that in the liver, but I'm not usually to see that in the lungs.
Yeah.
But something like that.
Oh, you are so smart. Let me show you something. So smart. Everything you said. Empyema, staph aureus, strep, all the usual stuff. TB, brucella, you said. It's very unusual, but cystic should make you think of a parasitic infection. And it actually turns out that presumably this is in Bulgaria, in Eastern Europe, there's a high rate of echinococcal infections, very high. It's one of the highest in the world. And so, I think you don't know. You probably should consider treating for pyogenic bacteria, staph or strep, but the cystic nature helps you consider echinococcus. And echinococcus is notorious for producing a lot of fluid. And so that's another clue for it. It has a characteristic very salty sputum associated with it. So if your patient is coughing, you can ask that question too. But I agree with you. Staph, strep, but in this case, you probably should look for echinococcus, but not presume that that's the case based on the fact that it's cystic lesion. And Marcella, you're right. It's usually right-sided because it's associated with the liver, and the liver goes right into the lung on the right side. But left-sided disease is described, and you can get echinococcus anywhere, in the brain, in the heart, in the muscle, in the vertebral column, even osteomyelitis. So it's tricky, but I think I would look for it here. All right, Ines, back to you, my friend.
Okay, so I will give you the result of the Torres synthesis. So there was something very that I never saw before. It was this milky white appearance of the fluid, very typical. And we had the pleural cholesterol, which was elevated. So that pointed toward exudate. And then we had the pleural fluid triglyceride, which was superior to 1.85 millimole per liter. As I said, cholesterol was elevated, and the leukocytes, which were under 1,000 millimeters square. So with that, does it, I don't know, ring a bell?
She's so kind. She's giving us more and more clues. Marcella, what do you think about that Torres synthesis?
Yeah, that was quite surprising because it was a classic step 1 exam, for example, question. It would lead me to a chylothorax because of the high cholesterol. So it would be a lesion to the lymphatic ductules there. So not sure if it would be an infection that maybe compressed the region there and caused that. I'm not sure, or a trauma or something like that. Or if the patient was in the hospital and he had a procedure and it resulted from that. So I am wondering that, but this milky appearance and the cholesterol lead us towards the chylothorax, I guess.
Absolutely superb. I couldn't agree more. I think that when the triglycerides are elevated, you basically confirm that there's a chylothorax. And it's tricky. You said trauma, surgery are 50% of the causes. A small fraction is because of venous hypertension. So patients can have SVC syndrome or pericardial effusion causing a chylothorax. And then we go back to the infections. So the infections that cause chylothorax are granulomatous infections. So we'll have to think about those. But yeah, I think we confirmed a chylothorax, and now you have a schema, right? You're like, what? I know that whatever this is, it'll be the cause of chylothorax. And the hard part about it is how do we find the answer to the cause? And that is a little bit tricky. And I'm curious, Ines, how did you make progress after this point?
Okay, so what I didn't tell you is first, when we met the patient, this was the history. So he told us nothing happened. And he's a farmer. So we were like, this is strange, like something is missing. And then his wife told us that actually he hit himself at the right side, at the left side, on the left side with the stick. Like he was, I don't know, he was doing something. And, 3 weeks before that. And then, so this man was transferred, to surgery because 2 days after his lungs was like full with fluid again. And so it was sure that it was a chylothorax, but actually it was just a traumatic chylothorax. And it was like, we talked with his wife like a few days after. So at first it didn't occur in our mind. And so it was just to show you like the importance of a very good history. Like it can really guide your diagnosis.
Oh my gosh, Marcella, what do you think?
Yeah, I am like really surprised, and it's like Ina said, history is so important, and sometimes like a lot of times maybe the patient doesn't think it's so important to say something in the days before the presentation. But I'm just curious about the fever, if maybe the chylothorax was infected, or if because of the inflammation and all the process he had the fever, because it was quite a high fever.
So he was sent for pleural debridement via video thoracoscopy, and then 2 indwelling chest tube, were placed, but there was actually no sign of fever. And this was like, we still don't know because nothing came back positive. And, like there was a lot of tests that were done, but nothing came back. So I don't know.
It's so intriguing. I love that we're ending with I don't know, because the truth is most of the cases that come in through that door are people you try to make a best guess with, and a fraction of them for sure. But I think that he has a chylothorax, and if you don't find a identifiable cause, the only cause that doesn't leave an imprint in the form of cancer or infection is trauma. And so I think that the fact that you didn't find anything, and when you add it with the history, is very, very telling. So how did you treat him, and how did he do afterwards?
So he was treated by, he just had like an antibiotic therapy. And then he was also, because of the chylothorax, so he had total parenteral nutrition. And, like his symptom resolved, like I think he left 10 days after. And then we saw him, so after the surgery, and we saw him like, I saw him actually 2 times, and he was completely fine. Like he's doing well and everything is back to normal.
Yeah, it's incredible. And that's an absolutely amazing presentation. So well put together. Clearly, we put a lot of work into this case with the PowerPoint that you shared, and we really appreciate you sharing with us today. Marcella, how did that feel to facilitate your first report?
Yeah, it was amazing. I love it. Yeah, thank you so much for inviting me. I had a lot of fun, and yeah, thank you so much, Ine, for the case. It was an amazing case. And taught me a lot.
I can easily see why you pulled in a record crowd today. Over 50 people to learn from your teaching. It was really, really well done. A delight. Andrea's giving you the thumbs up. And speaking of Andrea, pass the mic you to teach us, my friend.
Hi, thank you very much for the case. So we start with a patient with chest pain. When we have chest pain, we have to prioritize the hair over the lung. In fever, it's the opposite. You have to prioritize the lung over the hair because it's the lung that has direct contact with the exterior. And when we think about fever, we think about inflammation, infection, autoimmune disease, or malignancy. Because the patient had a pleural effusion, well, we suspect that the patient had a pleural effusion. So we wanted to, because we know that normally they do not cause distress because the other side, the other lung can compensate unless the effusion is very big. Because the patient had the antecedent of being a farmer, we talk about causes of patients, of farmers with pneumonia could be Legionella, Q fever, brucellosis, and a farmer with cystic lesion, it can be histoplasmosis, tuberculosis, echinococcus. Echinococcus tends to be on the right side because of the liver. There is a 60 lesion in the chest X-ray. It makes you think about parasites. And when you found high triglycerides elevated in glycosynthetase, it's most likely to be chylothorax. And normally trauma is the only cause of chylothorax that does not leave an imprint. Thank you very much.
Oh, so good. Thank you, Andrea. Thank you, Marcela. Thank you, Ines. I feel like I'm in a crowd of absolutely incredible trainees and doctors. And thank you all for joining us today. We're excited to see you again tomorrow for RLR at the exact same, well, no, not the same time, 30 minutes before. Bye.
Bye. Thank you, everyone.